So what we would like to do is just give you a little bit of context, and we will share this presentation. So we'll do it in turn and give you context. And context goes back to the 1980s, and some of you will remember that. So the context for the 1980s is that there are three events which coincided together. The first one was the discovery of prostate-specific antigen testing in the late 70s, adopted in the 1980s for testing and for the diagnosis of early prostate cancer. What it did is it alarmed people for the possible presence of prostate cancer, but it didn't actually say that the patient had prostate cancer. In parallel, the biopsies of the prostate were evolving using transrectal ultrasound guided biopsies. When I was trained as a resident, we used to put the finger in the rectum with a glove, with a needle much bigger than the needle that's being used now, and guide the needle through the rectum into the prostate. This is how we did biopsies. And this obviously was a revolution at the time to be able to do it under image guidance, because you had to be really crafty and lucky not to biopsy your finger as well as the prostate when we did that. And the third one was the actual operation of radical prostatectomy, refined by Pat Walsh at Johns Hopkins, who popularized the operation, made it reproducible with skills which were transmissible across surgeons. So the diagnosis of prostate cancer exploded completely in the late 1980s and in the 90s. And the digital rectal examination was still the preferred way of feeling the prostate, testing the prostate, together with PSA. If you went out and did PSA on men between the age of 50 or 70, the bottom line is that you will find a diagnosis of cancer in 2 to 4% of the men tested. Now, this really produced a global challenge, not just in the UK, but everywhere. And that global challenge, you can see what that means on the left-hand side of that slide. You see blue bars and red bars. The blue bars are the incidence of prostate cancer, and this is a WHO graph. And the right side is how many men die of prostate cancer. These are the red bars. And if you go towards the down, the south of the graph, in the developing world largely, you can see that the bars are small, but of almost equal size. And as you go further towards the west and the north of the globe, you can see that the blue bars are much bigger than the red bars. And what that means is that many more cancers with prostate cancer are being diagnosed compared to the number who actually die of the disease. And in England and Wales alone, in 1991, there were 34 radical prostatectomies performed by one surgeon in London. And as time goes, you can see the exponential increase in the number of radical prostatectomies because people were receiving PSA as opportunistic testing for prostate cancer. And the current rates were in 2019 reached a peak, 6,988 radical prostatectomies in England and Wales alone. And in 2023, a decline, and some of it, I hope, can be explained through the impact of the ProtecT trial. So all these together have created new problems and new dilemmas and a real challenge. And the introduction of these new terminologies for prostate cancer, which were overdetection of cancers which will not cause harm through the lifetime of a patient, overtreatment, because the word cancer causes a lot of anxiety and makes people go and receive treatment. They want to get rid of it. And undertreatment, because we still see patients who die of prostate cancer despite everything. So a real challenge and problems. And the 1990s, therefore, were plagued with lack of evidence. And there was no evidence that PSA testing and treatment of localized prostate cancer improved survival and quality of life, irrespective of the Gleasons at the time. As you said, we were not as well informed about the value of the Gleasons as we are now. There was the threat of an increasing burden to healthcare providers and society across the world, particularly in the Western Hemisphere. Treatment options had never been compared previously. So patients were given advice about receiving radiotherapy or surgery, very often based on the biases of the treating physician. And Jenny and I actually published a paper on that back in 1999, which showed that the doctor who delivers a certain treatment will advocate that treatment for the patient, even if the evidence for the benefits of that treatment is not there. And finally, there was a profound lack of evidence of what is the trade-off between the cancer benefits and the side effects of treatments when they're given. This was not known, and patients therefore could not make the right and informed decisions. So we started to design this, what was perceived as a completely crazy project by our colleagues, to invite 100,000 men for PSA testing across 9 centers of the UK. And we anticipated that we would diagnose around 2,500 prostate cancers, and we would invite these men to be randomly assigned through a well-conducted randomized control trial into the 3 common options that were available for these patients: surgery with radical prostatectomy, open at the time, not robotic or minimally invasive, radical radiotherapy, or conservative management, which we didn't even have the terms active surveillance, as you said earlier, or active monitoring. So we started with this conception, and the primary endpoint was going to be how many men die of prostate cancer, with secondary endpoint of how many men die full stop, how many develop metastasis and disease progression, and most importantly is to address the issue of the trade-off. We decided, and this is, Jenny's genius and expertise really was to bring an amazing patient-reported outcomes piece of work so that every patient is evaluated. And when we tried to put this to funders, and as I may have said earlier, we tried for 5 years to get this funded, both in the UK, various funding bodies, and Europe as well. We repeatedly failed, and eventually we succeeded to attract the attention of NIHR, the National Institute of Health Research, through a Health Technology Assessment Board, who said, yeah, we're not quite convinced that you could do this. And this is largely because most of our colleagues said it is impossible to diagnose a patient who's healthy with prostate cancer and then to give him a random allocation of one arm which will have no treatment in it. It said, you're crazy, it is unethical, you shouldn't do it, and we don't think you will be able to do it. So NIHR saw the light, or HTA rather, because NIHR didn't exist at the time. And they said, yeah, okay, we like your ideas, but we don't think you can do it. So we want you to do a feasibility or a pilot study to demonstrate that you can do it. And if you do, then we'll think again. And I'll pass on to Jenny now to explain to you about the feasibility.
Okay, thanks. Yeah, so we set out with the feasibility study. We worked really hard. It was a 2-year study, as you can see, that was funded. And at the end of the first year, the funder wanted to know how we were getting on, because they really didn't expect us to be doing very well. And what we were able to show them at this review meeting was that we were able to go out into the community, that men would come in for PSA testing, get the diagnosis of prostate cancer, around 3% of them. We also had nurses running those clinics, and they did an absolutely brilliant job. But when it came to recruiting the men to the randomized trial, we were, like everybody thought, struggling. So we were trying to see if the men would come into the 3-arm trial, but actually those who were interested in the trial mostly wanted to come into the 2-arm trial, comparing the 2 radical treatment options. But actually most of the patients didn't want to come into the trial, and they said they wanted surgery. And so we could have been closed down at that point, but what we've done, because of my background as a social scientist, is we embedded into the study a lot of qualitative research to understand the recruitment process. And that really involved the participants a great deal. So we interviewed quite a lot of the men. We interviewed the clinicians to see what their issues were about the design of the study. And uniquely, we audio recorded the appointments between the clinician explaining the trial and the patients listening to that. And we could hear both what was being said and how the men received what they were being described. There was a small number of men who did agree to take part in the trial. And funnily enough, they were all patients that Freddie had explained the trial to, because he was committed to it. He was the chief investigator. He had a balanced idea about these treatments, and he was explaining things in a balanced and reasonable way, but his colleagues, not so much. And so we used this qualitative research to work out what was going on, and it was quite clear what was going on. So when we listened to the appointments, first of all, most of the urologists were describing surgery first. They always described surgery first in great detail with enthusiasm. They then described radiotherapy with slightly less enthusiasm and less detail. And sometimes they didn't even mention the conservative arm. They meant to, but they didn't quite get around to it. Or they called it watchful waiting. And as Mark said earlier, I had a patient who sat with me and I said, what did you think of the trial then? And he said, well, I don't want that watchful waiting. That's where you watch and I die. And we thought, oh no, that wasn't our intention at all. We were doing repeated follow-up, regular monitoring. And so one of the patients said to me, well, why don't you call it monitoring? It's active monitoring. So that's where the name came from, the active monitoring name. And the patients and recruiters were struggling with lots of aspects of the trial, but we were able with these methods to actually do something about it. So we then went on to really think carefully about what the conservative option should be. We called it active monitoring. We spent a lot of time discussing it as a clinical group, exactly what we meant by that, because we didn't have repeat biopsies in it, unlike active surveillance. So we reconfigured the study around active monitoring. We made the recruiters explain active monitoring first, so they would actually do that well, and then they could explain they were more comfortable. So and then we put in place a lot of training for the recruiters to help them explain the study as Freddie was doing in a balanced way and addressing the difficulties and issues that some of the patients were having. We wrote all this up, of course, as in the usual way. So where would you go on? Yeah. But what happened then was that after the feasibility study, we were able to show the funder that we could do this. We were able to recruit the men. The number who came in and agreed to be randomized, as you can see on the right-hand side, it went from 40% agreeing to take part through 50, 60, up to 70% by the end of that second year. So in that 1 year, we made all these changes and the study was suddenly possible. And the funder had to fund the rest of the study, and we recruited right the way through to 2009. So this is the trial recruitment as it finished. We were pretty well on target for what we said we'd do, and we randomized 1,643 men. They agreed to be randomized between active monitoring, as you see now in the green box, and surgery and radiotherapy across all these sites. So I'm now going to hand back to Freddie to talk about what the results were on the clinical side.
Thank you, Jenny. So just to remind me, the purpose of the study was to evaluate the comparative effectiveness of active monitoring versus surgery versus radiotherapy to see whether they made a difference in mortality. So we first published our 10-year outcomes in 2016. And 15-year median follow-up outcomes in 2023. So what did we find? Well, after 10 years, you can see here the prostate cancer-specific survival graph. On this axis here, it's the probability of surviving prostate cancer, and on this axis here, it's the number of years, so up to 17 years here. But you can see that at 10 years, the three arms of the study, or the three groups, active monitoring, surgery, and radiotherapy, overlap completely. You cannot separate them. So at 10 years, we found that mortality from prostate cancer, irrespective of any of the treatment, was very low at about 1%, with no differences in treatment. And what we found at 15 years, that has not changed, except the mortality increased a little, so it went up to 3%, but we still have not seen a difference between the three arms. And when I use this graph now in the outpatient department in consultations to tell patients, I tell them, as long as they have low or intermediate, particularly favorable risk intermediate, I'll tell them your risk of or your chances of surviving this cancer over an average of 15 years from now is around 97%. And for them, it is a piece of good news. The second piece of good news is that there is no difference, and this happens irrespective of what you choose. So why do we bother talking to patients about treatment? Well, it's because of this slide here, which shows you, again, the difference between active monitoring, which is the dotted green line, which is now separated from the other two lines, which are superimposed still, surgery and radiotherapy. So what this one tells you is that at an average of 15 years, the risk of developing disease outside the prostate, metastasis, is in the region of 10%. But if you have treatment within 12 months from the diagnosis, that risk is reduced from 10% to 5%. Putting it in other words, it's 1 in 10 men who have a risk of developing this, but not dying of the cancer. And if they receive treatment, it becomes 1 in 20 men. It's not zero by treatment. And the reason it's not zero is because we are still not able to stratify men properly when they are diagnosed with prostate cancer. Now, what happens to men once they go into active monitoring? And this is within the context of the trial. What you can see here is the two lines at the top, the red one and the black one, which show men who receive their treatments. Average 92% of all men receive the treatment. Active monitoring, we see typically what's happening in the general community is that at 3 years, approximately 25% of men switch over to one of the radical treatments. At average 10 years, 50%, 55% receive treatment. But when we looked at 15 years, there's a surprisingly slow rise from 50% to 61%. Now, what does that mean? A number of things. The first one is that about 40% of men never received radical prostatectomy, never received the radical treatment. And 25% of all men never received the treatment at all for prostate cancer. And this is, again, another piece of good news. The other thing to emphasize also is that we're exploring, and Jenny's leading on this, why is it that men switched over from active monitoring to a radical treatment? And the reasons sometimes, or most of the time, are very subjective. And some of the reasons are the anxiety that is generated by the diagnosis of cancer and men being really anxious, not wanting to continue active monitoring, or the physician becoming nervous about it, sporadic increases in PSA. So we're analyzing all of this, and hopefully we'll have some more data to be able to present and talk about. Now, Jenny will tell you about the patient-reported outcomes, which allows us to make this, help patients to do this trade-off between the benefits that you've just seen and the side effects of the treatments.
Yes, thanks. So like the clinical outcomes, we were able to publish these patient-reported outcomes in the same journal at the same time, at the same period. The patient-reported outcomes were complete data for 6 years originally, and then 12 years that I'm able to show you here. So the men completed this quite long study questionnaire. I don't know if you remember it, Heathor, but it was quite a long questionnaire. And 85% of the men completed that every single year, which is quite incredible commitment. And we produce these charts from that. This is overall health-related quality of life. And what you can see on the axis on the left is the score or the percentage. And over time, you can see how the different groups line up. And you can see for these major aspects of physical and mental health, anxiety and depression, there's no difference really between the treatment groups. But there were differences in functional outcomes, as you all know. And this is the item on urinary leakage. So this is the percentage of men needing to use 1 or more pads per day. And you can see a very clear difference between the different groups. In the red, you see the surgery group. You see all of them started at 0 pads. But in the surgery group, you can see immediately after treatment, there's a great increase in the number wearing pads. And then their ability to hold urine improves a bit over time, but once you get out to 5 or 6 years, it then stays the same at around 20%, going up to 24% over time. And this is really important because most of the studies that have ever been done, the other observational studies, all stopped around year 2 or 3. And so it was assumed that the level of needing to use pads would reduce further, and it doesn't, it continues. The active monitoring men, you can see there's a slight increase in the use of pads, and that's because some of them changed to the radical treatment, not much effect in the radiotherapy arm. And of course, the impact of this on men varies. We interviewed quite a lot of men, and here's some quotes from them. One of the men said, "I still wear a small pad just in case, because you don't want to have a damp patch or an accident. So some pads are used for protection." But other men experience much more severe impact. This one, it really changed my life. I couldn't go anywhere. I'm always thinking, what if I wet myself? It's in the back of my mind. If I bend forward now without thinking too much, I still do leak. So these effects, it's really important to be able to balance off these effects and know what other patients' experiences are like. So sexual function, we also know is affected by the treatments. And again, you can see here, this is the item on erections firm enough for intercourse. You can see at the beginning, they all started at around the same level. But again, with treatment, you can see the surgery arm affected. They have immediate low sexual function. And there's a little recovery, but not much. And it stays at that low level throughout. The other groups, radiotherapy has a bit more of an improvement because they stop taking the hormones, but it's always a little better than in the surgery group. In the active monitoring group, you can see the decline over time with increasing age, and some of them switching to radical treatments. It's interesting that they all end up in the same place. So sadly, sexual function does decline over time to a low level, but you can see very different pathways to that because of the different treatments. And again, the impact can be variable. So one man said, you know, I've been married for 36 years and we've just got to the point now where we avoid the situation. You're so disappointed afterwards because it's never what it used to be. And another, knowing now that I might not ever have sex again, I try not to think about it because it does crack me up. And these quotes really bring home to you the importance of these issues. And they need to be taken into account before a man decides about treatment. So you're going to do the key messages, Freddie?
So what, just to summarize really the key messages from ProtecT so far, and remember, we're at 15-year median follow-up. We're hoping to go to 20-year median follow-up, which is going to be unblinded at the end of 2025 to see whether differences are still there. So the most important one is that the risk of dying from clinically localized prostate cancer for low and intermediate disease at 15 years from diagnosis, irrespective of treatment, is very low, 97% survival. The other finding, which we didn't discuss in detail today, is that even in men whose cancer spreads outside the prostate, they really can live a very long time and may well die from other causes than prostate cancer. And this is quite an interesting observation and phenomenon. The side effects of radical treatment can continue to affect some men's life very significantly, up to 12 years after treatment and possibly longer, and we still don't know. So what do these findings mean? Well, it means that men who are diagnosed can now take that time to assess the trade-off between the benefits and the harms of each treatment option. Men with low and intermediate risk disease can now seriously consider active surveillance monitoring safely. And the 20 years will help us to decide whether that effect will continue in the future. And the issues continue. So I just want to bring home here a very interesting observation and a paper which is not sufficiently cited from the SPCG4 trial, the Scandinavian randomized trial, comparing watchful waiting at the time. This is an older study than ours, 1989 it started and reported in 2002, compared with radical prostatectomy. And they looked at the long-term quality of life outcomes after surgery compared with watchful waiting. And they made this very, very interesting observation. You can see the bars, and you can see very clearly that when they compared the population of watchful waiting and radical prostatectomy with a matched cohort of men without the diagnosis of prostate cancer, what I realized is that it is not really the treatment that you deliver to the patient which damages the quality of life. It is the diagnosis of prostate cancer. And that's a real revelation, and not enough people pay attention to that. And what we really say is that every time a physician decides to put a needle in the prostate, he has the potential to give to the patient that he treats and biopsies the opportunity or the risk of having a new passport, and that is a prostate cancer passport, which is likely to change that patient's life forever. A few for good, but many with damaged quality of life and anxiety for the rest of their life. And this is something which is now gaining popularity, and we hope will continue to change practice across the world. We can't finish without thanking people. First, our funders, NIHR, which really had the vision to allow this study to continue for 25 years at the serious cost of £39 million, which funded all that effort over the years, which is being labeled as the most expensive study by NIHR.
So we'd really like to thank all the patients, of course, as the most important people in the study. And there's Ivor with us at the HTA celebratory meeting when you got to perform even more poems than you did today, which was lovely. And the picture on the lower part is the final participant who came in for a PSA test. You can see over 100,000 men actually had PSA tests.
So they've been at the heart, really, of our work. And here are the three culprits and brothers and sisters in arm. David Neal, who used to be my boss in Newcastle when I was there, and when the idea, he put Jenny and I in touch. We had our first coffee back in 1993, and we're always grateful for his partnership in the trial. The trial steering committee, International Trial Steering Committee, and I will point out to you Peter Albertson, who's in the back there, who's been an absolutely stellar member of that group, and I know that you've also awarded him a prize from your organization and patient group, and all these amazing investigators, nurses, physicians, radiotherapists, pathologists, administrators, trial coordinators in particular. And I do want to emphasize Athene Lane, who's been our amazing trial coordinator, without whom this trial would have been really, really difficult to complete and achieve. So we're humbled by the award, and we want to say you a really heartfelt thank you from both of us and on behalf of the whole ProtecT trial team. Thank you.